Hope this is the last lecture that we have to do remotely due to health issues. Things are looking up. Can you guys hear me okay? Is the volume?
Yep.
Okay, terrific. All right, so today we'll do a relatively quick look at some of the applications that cardiac SPECT is used for. And we'll see some case examples, and you'll be able to see the sort of good parts of cardiac SPECT and what it's really good at doing, and some of the shortfalls of cardiac SPECT as well. Were there any questions about the imaging technique itself? Do you have any specific questions from last or Monday's slides? Anything like that? Okay, if not, let's just get rolling then. Again, I'm not sure how long I'll last, but I'll go for as long as I can here. Okay, so if we review what it is we're trying to do with all of the imaging techniques in this in this course, we're trying to evaluate this disease, which comes down to, is there a flow deficit through one of these major coronary arteries that is causing either severe ischemia in a patient, that is low oxygenation in muscle tissue. And so if we have some kind of blockage, is there a part of the muscle that has low oxygenation and is headed towards death or a calamity? We looked at the introduction lecture at what happens inside the vessel, and it grows this plaque that starts to occlude the lumen of the vessel and can become a flow limiting lesion. And we'll see what that means. SPECT is a very good imaging technique to estimate what the actual flow is through that vessel. And the way you do that is you stress the patient and measure the change basically in the amount of material that gets through that stenosis. So this would be called a moderate stenosis. This one here would be called a severe stenosis. There is some blood flow that is actually getting through there. If you looked on a high resolution X-ray angiography image where you inject dye, you will see a very small, let me do the laser, here we go. There. So you will see a very small line on the X-ray angiogram showing, what, for lack of a better term, they always call a 95% stenosis. Normally, if you see this, where a vessel just stops on coronary angiography, there's normally some fairly significant symptoms that come along with that. One of the primary symptoms is death. 30% of people, the first symptom that they have heart disease is the fact that they're dead, right? They just suddenly die. And it basically means that the blood flow was cut off distal to this lesion, usually in a fairly acute and spectacular way, and it generates arrhythmia in the heart, and then they suddenly die. more and more, as people have become more aware of heart disease and diagnostic techniques have become better and more available, people know well ahead of time they do have, a disease that looks more like this, and become more aware that they might have a sudden heart attack, and they show up at the hospital in a decent time early after the onset, and they can open up the lesion and sometimes recover the tissue that is distal to the lesion. So the excuse me, the sequence of events here for a patient that's suffering from this disease is the hyperperfusion starts in the tissue. The tissue begins its metabolic alterations to compensate for the lack of oxygen. When you start looking at movies of how the heart is beating, the first thing that changes often is actually how the heart is filling. So after the maximum contraction, and you look at some interesting lack of quick filling, or diastolic dysfunction, that's called, can be a very early indicator that there is some kind of alteration to the muscle tissue. And this is well before you see something on, say, the patient's EKG. And then as the disease progresses, or the condition progresses, you'll start to see a drop in the ability of the heart to contract. And so the muscle won't contract as much. And eventually, if the ischemia gets bad enough, the muscle will just stop contracting at that location in the heart. And this produces a very obvious abnormality when you look at a movie, because now the heart is contracting in a very non-symmetrical way, and it's pretty obvious to see. And then somewhere after this, you start picking up ECG changes that are due to the change in the pattern of depolarization on the left ventricle, because you have reached a point of ischemia where that tissue is significantly changed, so it won't produce a depolarization excitation in the local tissue. So now you have something that's like a patch that isn't even depolarizing, and so you get a big EKG change on that. And then the patient will develop pain, right? Some of these things can swap orders. People can get pain early if they're lucky. And some people never develop pain and in fact have heart attacks and just think, well, I felt a little bad on Tuesday. And then you look at their heart and it's obvious they had a heart attack. The ECG, this is like an imaging technique in the sense that you have a signal and it's, has spatial coordinates, etc. But it's a classic way. It's very inexpensive. It's not terribly sensitive and specific in terms of heart disease, but in some cases where you have a severe heart attack, it's quite obvious what's going on. But you put a little patch that's made of a conducting gel that's connected to a little metallic part you can hook up to an amplifier. And so if we have three basic locations, we have the right arm, and left leg. When you measure the voltage across between these two leads as a function of time, when the heart contracts, because there is a voltage produced in the myocardium itself that has a gradient across the myocardium, that essentially maps up just by conduction to the surface of the patient and projects, if you can imagine, there's a picture of the relative voltage over the whole surface of the patient. And so you measure that picture at these 3 points and then look at differences. So the difference between the right arm and the left leg is lead 2 across the chest or across the arms here. The difference in voltage there is lead 1. These are all differential measurements, right? Here for the left arm to left leg is lead 3. These are, classic leads that even on a little cheap EKG, you'll see these leads. And then you can mathematically make a ground, say, or a 0 point in the center of the chest by just algebraically looking at these 3 voltages and measuring the difference between that mean and the right arm, that mean in the left leg, and that mean in the left arm. So this produces a nice map of voltage differences that cardiologists get used to looking at. If it's a 12 lead EKG, so you're doing a sort of high resolution map of this because you suspect the patient has heart disease, you might do this while they're under stress. Oftentimes, if they come in with chest pain, they'll put on a 12 lead EKG to take a look. And so there's, an extra 6 leads across the chest. So you get a very high resolution picture of the lead differences here, right over top of the heart itself. And ideally, these are their locations with respect to the ribs and the patient's chest. And there's also a lead on the right leg. And so now you can produce a lot of voltage differences, right? And so we had 1, 2, 3, remember those first 2, and then the algebraic combinations go here, right? And then these chest leads go over here, okay? And you can see that the time base is such that we get 2 beats per lead. So we got 1 here, and it shows you the pattern of the voltage. And so here's a positive deflection. This is, remember, the voltage across here, right? This one. So we get a small voltage when the atrium contracts, and then when most of the muscle of ventricle contracts, it creates a large positive voltage across the arms that drops back down. And then the heart is actually contracting at this time, and it'll be in a maximally contracted state here, and then when it relaxes, it repolarizes, and you get this positive voltage here for the repolarization. This looks pretty normal in that the height of all the peaks and their polarity looks normal. Okay, and so this describes when you plot out these leads, okay, what the voltage computation is for all of those leads. When a physician is looking at these, not the size of it, the relative polarity of different leads on a 12 lead EKG is important. But for our case, what we're really looking at in coronary artery disease is, can we detect when there's a large chunk of myocardium that is ischemic, right, and is not depolarizing properly. And so here's a normal EKG with the various features of the EKG labeled. And these, the PQRS is this little ventricular contraction part. P is the atrial contraction, and T, remember, is the repolarization of the ventricle. This segment here, even though the muscle's contracting, but all of the electrical activity is done with, right? So the voltages are gone, the heart's contracted, and then it relaxes to produce this. So this usually comes back down to 0 net voltage, say on lead 1, when the heart is in that contracted condition. If, on the other hand, there's a big chunk of tissue that is abnormal and is not depolarizing properly, this may never come back down to 0. There could be this residual voltage between 2 chunks of the heart that causes this non-zero voltage here, and this is called ST elevation, because it's between the S complex and the T complex. And if you see ST elevation in a patient, that is a very predictive sign that they are in fact having a heart attack. So they are in what you would call the acute stage of having myocardial ischemia or a heart attack. And at this point, you normally don't have to do imaging, any further imaging, right? So if they're in the ER and they show up and they see this, normally they're going to activate the cath lab, right? Because and this is the big binary decision. Does the patient go to cath now? Do you phone a physician and wake them up right in the middle of the night so they come in and do a cath and put a stent across whatever lesion is causing this? Or is it a false positive? And there's plenty of false positives. They'll go in, they'll see this, and they'll look at all the vessels and say, well, there's nothing severe enough in here that I'm going to treat. And so now you've kind of, caused a problem in that you've wasted a lot of resources on doing a diagnostic study that's quite expensive, and it's going to result in no treatment. So that's where imaging can come in. And if you're uncertain looking at this, then you can go to, say, a coronary CTA and say, is there a lesion there that is worth treating? Or you can go to nuclear medicine and say, is this being caused by a flow deficit, right? Or a lesion that is causing this flow deficit. And so here's an example where this patient, their coronary X-ray image, remember, we're going to inject a dye here, and the dye goes through the vessel, and then you get a projection image through the entire patient. But you can see at this point, it's a very valuable projection image, even though our resolution is low in the through plane orientation. Because of the dye, we get this great projection. And this you would call a 95% lesion, right? So you have a very narrow channel through which the blood is going. It does fill the distal vessel though, right? So blood is getting through there, either through this mechanism or another vessel is filling this vascular tree in a retrograde way. Highly unlikely with this much contrast here that it came back up in a retrograde fashion. But it's not unheard of that people have good collateral circulation for something such that they can get away with a lesion here because this tissue is fed by a parallel pathway, and that's called collateral circulation. And so some people are very robust towards developing a lesion like this because of that collateral circulation. Now, evolutionarily speaking, you would wonder, well, why don't you have a lot of collateral vessels coming down the heart so that you could lose a couple and still have normal flow, right? It's a good question, right? Because it certainly seems to be a weak point in our survival. So anyway, this lesion here caused ischemia down here, which is causing this strange ST complex here, right? So this is the QRS. And we're out to the T wave, and you can see that there's a very large voltage that is changing over time as we're moving towards the repolarization of the heart. And so this signal right here, you don't have to be an expert to read it. You can call that. Reading these, is part of what being a cardiologist is, and, being able to read these in a fast and accurate way. And there's, obviously an infinite number of permutations of this graph. And you can imagine that at this point, deep learning is probably all over this. I haven't read the most recent literature, but I'm sure that it will be better than humans without much trouble. So remember that what we're going to do if we get a positive vascular disease, say they come in and they have this, normally what's down the vessel is something like this critical stenosis. And we'll put a catheter into that vessel, see where the stenosis is from the image, the X-ray image, and then we'll maneuver a guide wire with a balloon on top of the guide wire right into the position such that it's centered up on the lesion. And there's normally little metallic parts out here that mark where the balloon is. And then fluid is injected into the balloon at a specific pressure. You don't want it too high because you don't want to bust the side of the vessel, that would be a disaster. That can happen. It's a very rare thing. But normally you inflate for a certain amount of time. This pushes the lesion, squishes it back into towards the vessel wall. Remember, we're fully occluded at this point, so there's no blood flow going here. So you don't want to leave it there for a very long time. And then when this balloon is let down, there's a fairly wide open pathway. And this is when, it's very interesting, this is when you get acute arrhythmias occur. When you reperfuse that tissue suddenly, oftentimes the patient can go into strange rhythm like VTAC or something like that. And so that's a very sensitive time. Oftentimes you pre-medicate the patient with a drug that will cause a loss in sensitivity or a loss in ability to depolarize in order to tamp down these electrical abnormalities when you get reperfusion all of a sudden. And it's thought that that's when a lot of injury occurs to the tissue, when you get all of this freshly oxygenated tissue come down or blood come down. This is done a lot, right? You know, there's a lot of heart disease and there's a lot of old people. And the primary risk for this is your age. So it just, you know, your risk for developing one of these lesions or having one of these lesions just, you know, goes up with your age. There's kind of no getting around it. And so looking for non-invasive techniques to decide whether or not this person is in this condition is a big deal, because so many of these are done. And so you can imagine if, say, even, you know, 30% of them or 30% of the casts that are done, X-ray casts, they just turn around and don't do anything. You know, that's a real waste of resources. So post intervention, the vessel looks great. This is why, you know, there was fantastic enthusiasm for this procedure, because you start out with a patient that looks like this, and often called very ratty, you know, vessel, in the sense it goes down to a 95% lesion, and then there's some thinning here, some thinning here, some thinning here. We've got all of these regions where obviously the vessel is full of lesions. And then post-procedure, this thing is wide open. You say, look at that stent there. You're saying, well, which would you rather have? You know, if it was you, well, I'd rather have this, you know. The question is, this is a really interesting question now. Even though it looks like this is a much better situation to be in, if you were not having an acute heart attack in this situation, if this was just observed and you had, say, mild pain and you're in a very stable configuration, getting this done, even though you would think it would increase your survival, it does not seem to, right? When you're in a stable condition. If you're in an acute condition and you have EKG abnormalities and obviously you're having a heart attack, then there is absolutely no question you want to move into this box, okay, as soon as possible, actually. And so there, casts like that, interventions like that will always be done, because it's absolutely clear that you survive better if you do it here. However, if you're in a stable configuration over here, you haven't had a heart attack, then it turns out, and there's a couple of very prominent studies that were done very recently, actually. And these are like sort of the acceleration studies of the universe, you know, when they first set out to see how quickly the universe was slowing down, they found it was accelerating. You know, they're big studies that were dedicated to find out how many more people survived in this box than this box. Like in this box, you'd have basically optimal medical therapy, the best drugs, you know. And in this box, you would have obviously a wide open vessel with a coronary procedure plus the best drugs. So which one of these conditions did you survive longer? And obviously they were just, you know, trying to measure how many more years do you get over here. It turns out 0. There's the same probability of having a severe event with, you know, if you're in here or in here, if this is stable. So if you're stable, it's probably best just to take the best drugs. So the perfusion deficit, that is the blood flow, which is causing the metabolic changes in the tissues such that EKG changes and you get pain and stuff like that. That obviously happens before any of those other symptoms. And the question is, can we use the imaging technique we're talking about, which is, SPECT, to detect those perfusion changes? And the answer is yes. If they're severe, there's no question you're going to detect them with SPECT. And here's a comparison of a CT image in which a contrast agent, a fairly high dose of a contrast agent, which causes the blood to go really bright on the CT image. And this image was made shortly after that injection. So as soon as they see the contrast amplify its concentration in the ventricle, then there's a fixed delay before you make an image. And when you make that image, the contrast has had time to go into the myocardium, right? However, you can see a very detailed picture of where this contrast did not go into the myocardium in this patient. And there's an apical lesion here, or an apical flow deficit. And when we look at it from a short axis view, if we cut the heart this way and look at the donut view, you see it's here on the anterior wall and partly on the septum. And then when you look at another long axis view, you can see the whole anterior wall basically is underperfused. And so this points to the major left anterior descending coronary artery is probably blocked fairly high up, right, in order to cause this large deficit. And so this is the CT. And so looking at the spatial resolution of this picture of the lesion, then you look at the same lesion on SPECT and say, okay, well, this is really blurry imaging, right? I mean, we've smoothed it out incredibly, but you can see definitely there's a deficit here. And so that flow deficit gives you a positive signal on the SPECT, and you probably are going to go to the cath lab at that point and see if there's a lesion that should be fixed. Oh, by the way, if you have questions, can you just just call them out, because I don't know if you're there otherwise.
Yeah, absolutely, we can.
Okay, thanks. So let's take a look. I mean, this is the thing that we've been looking at. And we can start looking at some case studies now as to what's going on here. We briefly looked at this slide on Monday, and showing the importance of doing attenuation correction for each patient. It turns out that there's two factors, obviously, that create a brightness in these pictures. One is how much, agent is at that location, and the other is how difficult is it for a photon to get out of the patient from this location, right? From this location, it is easier for a photon to get out and get detected than it is from this location. It's deeper in. So that term has to be entered into the model for calculating the relative concentration of agent here. You have a source term, which is the thing that we're trying to image, and then an attenuation term, which is proportional to all the pathways from there to the detectors, right? And when those attenuation corrections are done, the pictures do change.
I have a quick question about that. And maybe you're about to go into that, but do you know, being maybe more privy to CT technology, how exactly those like the beam hardening corrections work? Because I took the imaging lab with Francisco last quarter, and we did a beam hardening lab, and we were basically trying to guess how they did the beam correction.
Right.
And we could do it with a phantom a little bit. Theirs was still way better. We could do a little bit with the phantom where we knew the shape, but if we don't know what we're imaging, that's really difficult.
Yeah. Well, that is part of the problem is estimating. So you can imagine how it goes, right? In that your line integral from a source position basically takes you through different tissues, which you then have to model in terms of their spectral differences in attenuating radiation, right?
Mhm.
And having, so you have to, if you're going to do it in a super accurate way, you would need to like model that whole thing in an iterative process, right? Whereas you get pretty far by sort of modeling a constant depth and just saying, well, it's got an average attenuation, right? So you're going to get your sort of first order correction that way. Now, for attenuation, all we're talking about here in SPECT is attenuation. There is no beam hardening in a sense because our beam is absolutely monoenergetic, right?
Oh, I see. Yeah.
So basically, we start with 140 keV photon, and that's it. That's what we've got to work with. Now, it can lose energy in collisions, and so there's beam softening, but it's not really a beam, right? It's like,
Yeah, it just loses intensity, right?
right, it uses its energy, and you hope that you're going to filter those out anyway by energy um, triggering, right? So if it's low enough, you'd say, okay, that photon is probably a scattered photon. It's not our primary one. It didn't come from a straight route. It came
Mhm.
from a deflected route, so we're going to ignore it anyway. So
Mhm.
now, in this technique, you've got a pretty simple problem, right? Because I have a monoenergetic beam that if I detect it, say my detector's in this configuration here and it's coming out this way, then I can just integrate to that point and say, well, what is the relative attenuation of 140 keV beam through this pathway, and then just
Mhm.
bang it up, so you just model it with that intensity. So this is simpler, right? Then
Mhm.
CT is more complicated because you start with a polyenergetic beam, and
Yeah.
as you proceed through the patient, the beam becomes higher energy, basically, because more stuff is absorbed.
Mhm.
I think, I don't know the latest and greatest or even the oldest, other than the very simple beam hardening correction. But then the reason why the manufacturer is always going to beat you is they will not tell you the energy sensitivity of their detector. They
Mhm.
know, right? So they measure that when you fire, if you reboot a scanner, it will spend 20 to 30 minutes just scanning at different energies and recalibrating the detector.
Mhm.
So it knows like how sensitive is it in these bandwidths, right? And so when it's putting those together, it'll be in that. And I'm not sure you'd ever be able to do it, right? To get those calibrations. You might.
Yeah.
Um,
Have you ever met someone who worked for one of those companies?
yes. Yes, absolutely.
They're pretty tight-lipped.
Yes. It's very interesting. You become very disciplined working with those companies about what you can and cannot talk about. And
Mhm.
you just don't, right? Because it compromises different people and et cetera, et cetera. It's almost like when ignorance sometimes is power, because then you can go off and discover something and you discovered it. It wasn't given to you by a company.
Yeah. Yeah.
you know? So if you actually publish something and everybody knows everybody's tight-lipped and they're really disciplined about it, then yeah, you discovered that, right? It
Then
wasn't,
yeah, they'll just think you did it. Yeah.
yeah, that was not insider information. You just figured out a really cool phantom and a really cool experiment to measure that, right? So you can
Mhm.
imagine putting different filters in front of a beam on a CT scanner, like copper, aluminum, all plastics and stuff, such that how that changes the spectrum of
Mhm.
photons, because you can just look it up. And then you go through a series of experiments to do your own calibration, energy calibration of the detector or something. Right?
Mhm. Cool. Yeah. Hopefully learn more about that when we get to CT.
Yeah. Although we probably won't be doing a ton of basically beam hardening corrections now that, but we'll see how it goes.
Okay. Yeah,
So
thank you.
yeah, no sweat. So the the simple attenuation correction here of just having a different route from this part of the heart versus this part of the heart is absolutely necessary for SPECT, because when you don't do it, it looks like a lesion. It looks like a perfectly, uh, modeled flow deficit in this part of the heart. So it really simulates a positive flow deficit. If we, I think we did this in one of the early lectures where we look at the standard coordinates that images of cardiac perfusion are given. And remember, you look at on the donut, these are called the short axis. They're cuts this way through the heart, slices this way. And we're looking from the apex of the heart up towards the base of the heart, or the feet of the patient up towards their head. The right ventricle is on this side of the image. So this is the septum. This is the anterior wall, lateral wall, inferior lateral, and posterior or inferior wall. And given on this diagram is also color coding for which the highest probability of which vessel is feeding that location. And so the reason cardiology sort of settled on this type of resolution for these maps is that basically all you needed to do was tell the interventional cardiologist or someone like, we think it's the left anterior descending artery. And if we look at this and say, well, here's the LAD coming off here. So this is the left main coming out here, and then it breaks into two. It goes into the circ, which goes around the back of the heart, and the LAD feeds the front, or the part of the heart that's under the chest wall. Circ goes around the back. So does the right coronary artery. It goes all the way around the back and then feeds the posterior wall. And then those regions are color coded on here. So you can see that the LAD feeds this part of the septum and this top of the wall, and there's a mix of LAD here, or circ. Excuse me. And so when you see a deficit, so remember that deficit we saw in the MR, and it was basically all here, then it was fairly obvious that was the LAD, right? That was this vessel. And this vessel, this is called the left main. It's also called the widowmaker, because if you have a big lesion here, then you knock out this and this, right? And what can get worse is that the circumflex and the right coronary artery, somewhere in your embryonic development, you get both of these arteries feed the posterior wall. And then somewhere along that development, one of those vessels takes over and is the primary vessel. And the other one sort of withers away, if you can imagine. Like, why would you waste on them? But it does, it withers away. And so in some people, your LAD feeds the front of the heart, and the circ feeds the back of the heart. And so if you have a primary lesion here, then you're in really big trouble. So, so these, if we think about these maps, when we go back to this picture, right? These are the short axis. You can actually see part of the right ventricle out here, and this is the septum, anterior wall, posterior wall. So that gives you the coordinates there. And then the long axis views, we have the anterior wall up here and posterior wall down here. Here's the septum and the lateral wall, and that's the RV over there. And so you can post that up as a bullseye plot, which is essentially this coordinate system here, right? In the inner ring of the bullseye is this data, mid ring is this data, and the outer ring is this data. So when we go to that bullseye, that's what that looks like. So here's an example of quantitative values measured with SPECT. And this is a very important point, is that given a specific model, you can look at the brightness and calculate, excuse me, what the flow rate was or is to that chunk of tissue. So this is the apex, the mid, and up at the base. And you can plot that. You actually measure it in absolute, coordinates, which is milliliters of blood per minute per milliliter of tissue or per gram of tissue, right? And get a quantitative value. And it turns out when you're at rest, you're about 1 mil per minute per gram, which is an interesting number, right? Why does it come out to 1? But anyway, such is life. So in a sugar cube size volume of myocardium, over 1 minute, you'll have 1 milliliter of blood will pass through that sugar cube and perfuse it. If you run for the bus or you get on your bike and you pedal really hard, get your heart rate up to, for me, a high heart rate's like 150 or something. For younger people, it's like 180, 190. If you get it up there, then your blood flow per gram of tissue in your heart goes up really high. And in a normal person, a normal young healthy person, it's going to go up to 5 milliliters per minute, right, per gram. And you can see in this patient, when they stress the patient, they got these results here, right? And so you can see out here and out here and here, we're only getting to 2. And so there's a fairly significant deficit in response to stress in this patient. And in fact, if you look over here, we started at 1 and it went down to 0.7. And so there's, something untoward is happening here. There's blood flow is being stolen from this region and going elsewhere. So this is not a good map to get if you have a stress test with nuclear medicine, right? However, what's really interesting, and one of the projects somebody could do is to look at the imaging follow-up for a trial called the ischemia trial, which showed that even patients with positive blood flow drop, like if they have a positive stress test, and that is their perfusion dropped or didn't rise as much as it should, that was not a terribly good predictor of who was going to have events, in the next 5 years. Which came as a surprise to everybody, basically. And then this is a brand new trial. This thing came out 2 years ago. And the only thing that actually correlated with events, these are stable people with perfusion deficits is the cadre. And the only thing that really correlated with events was amount or plaque burden in the vessels. So when they did the CT, just as a side thing to confirm basically that there was or was not a lesion. And it turned out that the only predictive thing for how people were going to do was how many darn lesions did they have, basically. If they had a ton of lesions, they did worse. It didn't matter about their flow. It was a very, very interesting result. And but I'll list that up as a set of papers that look at the primary ischemia trial and then the imaging, the sub-analysis of the ischemia trial to look at the different imaging technologies. So, but this is a big deal for cardiovascular imaging or especially in ischemia is how do you basically generate higher demand to uncover cardiac disease, right? That isn't obvious at baseline. So if you're just sitting watching TV, you don't feel so bad. But when you go run to catch the garbage truck and you grab your thing and run to the edge of the driveway, you get chest pain, right? And this happens over and over. So you come in and you're going to do a stress test with your cardiologist. And how do you generate stress? Well, here's 5 different ways to generate stress and then take a picture. One is you put the patient on a bicycle, an exercise bike, right? It's a stationary bicycle, or you make them walk, right, on a treadmill kind of thing. And so here's the basically, you know what this does. Anybody who's gone jogging knows that your heart rate goes up and your blood, your perfusion goes way up. You can generate arrhythmias, right? And you hope this doesn't happen, that the patient's blood pressure all of a sudden drops precipitously, right? And then you've got a big problem on your hands. But one of the problems of doing it, this is a great method of generating stress for the heart. If you, they even have bikes that you can put in a scanner that in a recumbent position. I mean, you've seen these crazy guys on recumbent bikes, like while riding down the road, right? Well, you can put that same kind of geometry together for a scanner, and then the patient pedals while they're in the scanner, and then you stop pedaling and take an image. The problem with that is, with this type of stress, the patient really starts breathing hard, right? There's no way you're getting around that. They've got to breathe. So you say, hold your breath for 30 seconds. That's not going to happen. They're going to be done. However, it's a really good way of doing stress. Then there's 4 drugs. Adenosine, widely available, not expensive, right? It basically, when you inject it into a patient, opens up their vascular bed, right? So all of their vessels dilate. All of the vessels that control dilation dilate. And then so that, without doing any exercise, all of a sudden the myocardial blood flow, if you're normal, jumps up, right? And so you look at that in a patient for regions in which it doesn't jump up. Regadenoson is this is probably the newest of all of these drugs. It is a very good method for making hyperemia or high blood flow, and it has a very short half-life, right? So it basically, you can shut it down quite quickly. Again, all of these have side effects or limitations, which are that you can create cardiac rhythm abnormalities. And so, you're stressing the patient and they might go into some kind of strange rhythm, and you have to be ready to deal with that. Dipyridamole is a different chemical than regadenoson. It is a very good method of increasing blood flow. However, it has a really long half-life, right? So if that blood flow is causing a real problem for the patient, you're kind of stuck in this condition. So you have to have a way to get out of there. And then dobutamine is, all of these are directly changing the blood flow to the myocardium. Dobutamine is like adrenaline in that it creates higher contractility in your heart. And when you watch somebody on this using echo or MRI, basically their ejection fraction goes way up, and so their heart's working just like they're riding a bicycle, but so mechanically it looks like they're riding a bicycle, but they don't have to breathe hard, right? Because the only thing that's really cranking is their heart. Their legs and everything else don't have oxygen demands. And so they can quietly lie in the scanner with this really cranking heart, and you can take pictures. And this is used often to do real-time stress testing with echocardiography. And you'll put an echo probe on the patient and crank the dobutamine dose through about 4 different levels. Watch how the heart responds to those levels of stress. And if at a certain level of stress, the mechanical contraction of the heart becomes quite asymmetric or just drops out in certain places, then you call that test positive and you stop. And then that is a positive sign that there is a blood flow issue in that person's heart. So all of these are done commonly. I would say regadenoson is the one that's done mostly now in SPECT, right? So you can take a rest and you give the patient the drug and take a stress. And often now what's done is you do the stress first, and then you wait, say, 20 minutes and do the rest, follow up. And we'll see why in a few cases. And that is that if you have a deficit that is fixed, so it happens with stress and then it takes a long time to go away with rest, that's called a fixed deficit, and that's indicative of worse disease state. I won't go into the detail. Oh, shit. I won't go into the details of these doses. You can look this over, and this shows where the radionuclide injection occurs, after you institute this stress. So here's a normal person. Their EKG, when they looked at it, there might have been a slight ST elevation or something, and so it was called equivocal. They couldn't really go either way, that it was normal or abnormal. On invasive coronary angiography, they saw a 30% distal LAD lesion. So that means when you looked across the vessel, it dropped its diameter only by 30%. Okay, so that's called a mild lesion, and a 50% diameter drop in the right coronary artery, and so that's sort of a mid lesion, it's not mild. But when the rest, or here's the rest scan and the stress scan, basically they both look normal, right? And so the view here is just like everything, there's nothing purple up here that has low flow values. It looks normal. So the flow was not affected by these lesions. You can also do a cool thing in that you can take because you're continuously collecting the SPECT data, you can break it up into time buckets. So if you're collecting the EKG, you basically look at the EKG and say, for the first 20% of the EKG, I'll reconstruct one image, and the next 20% and the next 20%. So I have 5 images. And then one of those images will be when the heart is most full of blood at end diastole, and then this will be end systole. And you can see the concentration of counts as the mechanics of the situation bring all the tissue together. So you get a much brighter picture at end systole than you do at end diastole. And this, I think I might have a movie. Do I have a movie? Yeah. Here we go. So here's a movie of normal perfusion. So this is end diastole, and then this is when you break up your SPECT image into temporal components. Excuse me. You can see the change in activity, and you can also get a relatively good / low low spatial resolution image of myocardial function. Not great though. I mean, this is used to generate sort of relative ejection fraction myocardial function, but I wouldn't recommend doing sort of high resolution wall motion abnormalities with this type of imaging. However, it comes for free, right? I mean, you're basically collecting this data. The other thing is that if your resolution is able, to resolve these different configurations, you should probably pick one as opposed to average them all together, right? Or you could at least, have a range of positions, available, or put a model motion in and do that as well before you made your bullseye. Here's the raw data. And so it gives you, we saw this before, it gives you an idea of what the signal to noise is for our heart and the background. You can see the sort of hashy noise here. And this mostly comes from photon counting statistics. There just aren't that many photons detected in SPECT compared to, say, CT. CT, you have an enormous number of photons that hit the detector, unless you're doing very low dose. This is like super low dose in the sense that you don't detect that many photons. Unfortunately, it's not super low dose for the patient, because they have this material injected into their body. And so they're being irradiated from every organ for however long, the half-life, 3 half-lives of that material. And so it turns out that the dose is pretty high. And here's a, excuse me, I'm gonna have to stop after this, I'm afraid. So this is CT. These voxels, anyway, are like a 0.5 millimeter by a 0.5 millimeter by a 0.5 millimeter. They're very, very tiny compared to the voxels from nuclear medicine. We see a soft plaque here causing what, if you look at the diameter of this vessel and say, well, what's the diameter of that? It's at least a 50% stenosis here. And it's detected with pretty high sensitivity, the presence of that stenosis. And then there's a calcium lesion here, and there's obviously some other lesion down there. So this is clearly a positive scan on CT. Like, this patient has coronary artery disease, and this is the lesion here. On the rest stress nuclear medicine does not come up as positive, right? So the big question is SPECT sensitivity too low, or is CT sensitivity too high? Where do you, if you didn't do this at all and you just did this, should you send this patient to the cath lab and have this lesion stented? So this is the big decision point. And CT, historically, CT has not been overwhelmingly adopted by cardiologists because they feared that it would keep people out of the cath lab. It would be a gatekeeper to the cath lab. And so they did not want for their patients to send them off to some other department like radiology, and for radiology to tell them, no, you should not cath that patient. So it's a very human, emotional response, as well as, technical, in the sense that I want to be able to do with my patient what I feel is best for my patient, right? And not have a gatekeeper. They also economically feared that, well, wait a minute, if CT is the gatekeeper, is our cath lab going to be empty a lot? And we'll have this very expensive cath lab with no patients. It turned out to be exactly the opposite. That was the initial fear, right? And that was a fear of 20 years ago. Then when CT became this good, the reverse problem happened, in that when patients went to CT, many more of them wound up going to the cath lab than previously. And so it became a gateway to the cath lab. And so you had this huge line develop at the cath lab with this. And so they, head to head between CT, echo, nuclear medicine, and which is the best way to push the cath lab, is really still underway. But for my money's on CT. I put it on there 10 years ago. It's going to be the way all of this is done fairly soon. You know what? I'm going to have to sign off. I will put this entire, I think there's a movie I have for the rest of the explanation of this, of these cases where you have a lesion show up in stress and it resolves at rest, versus one that's in stress, it doesn't resolve at rest. So this is probably like the whole apical cap is probably an infarct, etc. But I think that will be on the movie. And so here's function again in somebody who's quite abnormal. And then on the movie, there'll be a discussion of, this kind of data. This is from 2004, right? And this is how SPECT became completely a huge growing market, was analysis like this saying, what is the change in, my positive, CAD prediction if I do SPECT on top of the ECG, right? And so it's the change in test probability if you have a positive MPI. So I'm sitting here with say a positive echo or a positive ECG, and I'm only 70% sure. The nuclear medicine will push me up to this part of the graph. I'm not sure any of this has been reproduced, to tell you the truth. I really don't. Given the results of the ischemia trial, which was from 2020, I'm not sure how this thing actually worked out. And so there's some other data here in terms of sensitivity, specificity but this is pretty old. I think this is from 2013, which is pre-ischemia trial. But you can see the sensitivity of, say, a CTA is like 95 to 99%. It's going to pick up every positive lesion. However, it will also pick up people that turn out to be negative on CAF, right? And so this is the kind of downfall. We'll look at that. But for what we're looking at in terms of, this is nuclear medicine here, myocardial perfusion. So it claims to have a sensitivity of 90% and a specificity of 75 to 84. And that's, could be true, but if you look at the trials, you have to ask yourself, well, which set of patients was this developed on? When you do these trials, you have to be really careful that you don't sub-select a set of patients in which this becomes a much easier task, specifically this one. So in the real world, when you look at myocardial perfusion imaging, I can't imagine it's actually 90%. My experience tells me it's like 70%. We miss a lot of people. Okay, and then we'll go into PET briefly later, but I'm gonna stop now because, again, I got this darn thing.
Thank you for doing this.
Oh, sure, no problem. Sorry about all the sturm and drang about the.
That's all right. Can I email you a question about the homework and the project?
Oh, absolutely. Absolutely. Please do. And I would like to start a discussion about the project, in the sense that I think there's 11 of you that are taking the course for credit, is the way it looks like from Canvas. And so we do projects in pairs. So I'll send out a list, and you guys can pick a partner. And then I'll also have a list of, potential titles and maybe some example projects from the past. But I'm very interested for you to pick an imaging modality and topic amongst that modality that is of interest to you, right? And just run with it and do what you want. It can either be a really in-depth investigation into that technology, and perhaps with some of your own simulations, or you can just go from scratch and I'm going to, completely simulate motion in CT or motion in SPECT or something like that, and just write a big simulation of that, right?
Mm-hmm.
Okay.
Great.
All right, guys.
The
Mm-hmm.
the proposals are due next week, right?
Oh, they are? Is that right? Oops. That ran away from me. Let's when are we deciding to present them? Wasn't that halfway through?
I think that was next week, right? Like week 5.
Oh, I'm probably gonna push that back. If you don't, is that okay if I push that back a week? That kind of.
Probably so.
Yeah, I think that'd be good.
Yeah.
Okay, so let me look at that. I'll send out an announcement, but I don't think we're gonna do it next week. I would like to give you a bit more time, and me a little more time to figure that out. Okay, thanks for pointing that out. All right, cool.
Thank you. Take care.
All right, I'll send announcements as to what's going on then.
Thank you, Professor.
Okay.